Hello everybody. My name is Maitri Prabhakar and this is a presentation on the perinatal transmission of Zika virus. Zika virus is an emerging infectious disease. Widespread transmission of Zika virus by Aedes mosquitoes has been recognized in Brazil since late 2014. In October 2015, an increase in the number of reported cases of microcephaly was reported to the Brazil Ministry of Health. This was way above normal. The normal was 92 per 100,000 per year. This prompted an investigation which strongly showed an association between pregnant women infected with Zika virus and their subsequent delivery of children with abnormally small heads. In November 2015, Pan American Health Association and the Ministry of Health of Brazil noted a marked increase in microcephaly cases. The World Health Organization in February 2016 declared Zika crisis a public health emergency. This slide and the illustration demonstrate the epidemiology of Zika virus. Zika virus was first identified in rhesus monkeys in the Zika forest of Uganda in 1947. Since then, it has circulated in Africa and Asia for nearly 60 years. That is until recently. In 2007, an outbreak occurred in Yap, Micronesia, which was the first human outbreak known, affecting nearly 75% of the population. From 2008 to 2013, only 4 studies were published on Zika, indicating a relatively unnoticed mild infection. In 2013-14, an outbreak of Zika occurred in French Polynesia, which was associated with an increased rate of Guillain-Barré syndrome. In June of 2015, first case of Zika was reported in Brazil, where an association between Zika infection and microcephaly was first noticed. This further spread to the Americas and the Caribbean. Currently, Zika has spread to more than 52 countries worldwide. Zika belongs to the genus Flavivirus. The natural transmission cycle involves mainly vectors from the Aedes genus of mosquitoes and monkeys. Humans are occasional hosts. The infection is similar to dengue and chikungunya, where it can be either asymptomatic or can have mild symptoms. Symptoms consistent with fever, maculopapular rash, and arthralgia. Birth defects such as defects of eyes, hearing, and impaired growth in children born to infected mothers are of major public health concern. There is no specific medicine or vaccine for Zika virus. Zika virus can spread through various modes of transmission. Mosquitoes, genus Aedes specifically, is the main mode. Mosquitoes become infected when they feed on a person already infected with the virus. Infected mosquitoes can then spread the virus to other people through bites. Zika can spread through blood transfusion, theoretically. As of current, there have not been any confirmed blood transfusion transmission cases in the United States, though there have been multiple reports of blood transfusion transmission cases in Brazil, which are being investigated. There have been one reported case of laboratory acquired Zika virus disease in the United States currently. Zika virus can be spread by a man to his sexual partners. The virus is present in semen longer than in blood. A pregnant woman can pass Zika virus to her fetus during pregnancy. In this presentation, we will discuss in detail about this mode of transmission. The figure in this slide shows the different modes of transmission of Zika virus in humans. Perinatal transmission is defined as transmission of a disease-causing agent from mother to baby during the perinatal period, the period immediately before and after birth. WHO defines perinatal period as the period commencing at 22 completed weeks of gestation and ends at 7 completed days after birth. CDC defines perinatal exposure to Zika virus as Fetal exposure to maternal Zika virus infection at or around the time of delivery, when a woman is infected with Zika virus within approximately 2 weeks of delivery. Publication by Westnard et al. First described the possibility of transplacental transmission or transmission of Zika virus during pregnancy during the outbreak in French Polynesia in 2013. A mother already infected with Zika virus near the time of delivery can pass on the virus to her newborn around the time of birth or during pregnancy. The presence of infective Zika virus particles in breast milk with substantial viral loads have been reported. Arbovirus transmission via breastfeeding has been previously suggested for dengue, West Nile, and yellow fever, but currently no reports of infants getting Zika virus through breastfeeding has been reported. Further investigation is needed in this regard. Currently, more than 5,200 cases of suspected microcephaly have been reported in Brazil alone, linking the causal pathway of Zika virus and microcephaly. The temporal link was first noted in 17 fetuses during the French Polynesia outbreak of 2014. The figure shows the severity of microcephaly associated with Zika virus. This slide describes the first studies linking Zika virus and fetal brain anomalies. In a study in Rio de Janeiro published in the New England Journal, among 42 women with laboratory confirmed Zika virus infection, 12 abnormalities were detected, including 2 intrauterine fetal deaths and 7 structural abnormalities like microcephaly, calcification, cerebellar atrophy, and ventriculomegaly. In another retrospective study of outbreak in French Polynesia in 2014, the estimated risk of microcephaly during first trimester was approximately 1%. The full spectrum of fetal outcomes resulting from fetal Zika virus infection in humans is not fully known yet, though the causal link of microcephaly and Zika is strong. Microcephaly is a birth defect where a baby's head is smaller than expected when compared to babies of the same sex and age. Babies with microcephaly often have smaller brains that might not have developed properly. Severe microcephaly is associated with Zika. It can result because a baby's brain has stopped developing properly during pregnancy, or the brain started to develop correctly and then was damaged at some point during pregnancy. Microcephaly has been linked with the following problems: seizures, developmental delay, such as problems with speech and other milestones like sitting, standing, walking, intellectual disability, problems with movement and balance, feeding problems, hearing loss, vision problems. Furthermore, subcortical and periventricular calcification with ventricular dilatation is also noted in Zika infection. This slide shows some of the relevant publications published in 2016 discussing temporal association of Zika virus and its perinatal transmission. Miller et al. Described 2 cases of Zika virus intrauterine infection associated with microcephaly and brain calcification diagnosed by means of ultrasonography during third trimester. Calvert et al. Detected Zika virus genome and anti-Zika virus IgM in amniotic fluid of pregnant women with microcephalic fetuses. This shows that Zika virus can cross the placental barrier. In February 2016, Lacker et al. Proved Zika virus infection was associated with microcephaly by demonstrating Zika virus in fetal brain tissue using RT-PCR assay. The complete Zika virus genome was recovered from the fetal brain of the aborted fetus at 29 weeks of gestation. The mother had had a high fever, severe musculoskeletal and retroocular pain, and a generalized maculopapular rash at 13 weeks of gestation while she was living in Brazil. Postmortem examination of the fetus revealed microcephaly with complete agyria, hydrocephalus, and multifocal dystrophic calcification in the cortex and subcortical white matter with associated cortical displacement. Brazil et al. In 2016 described microcephaly and said that it was not diagnosed until 27 to 35 weeks in a large Brazilian cohort. Diggers et al. Described a timeline of development of fetal abnormalities as shown in the slide. Fetal head circumference decreased from the 47th percentile to the 24th percentile as soon as 16 to 20 weeks. Zika virus is predicted to spread in the United States in 2016 due to Aedes mosquito spread. So, from a public health perspective, it is extremely important to enforce mosquito control. This slide shows the CDC recommendation of a testing algorithm for a pregnant woman with possible exposure to Zika virus, though not residing in an area with active Zika virus transmission. When the pregnant woman is tested and the test turns positive, serial fetal ultrasound is considered. If the test is negative, fetal ultrasound to detect abnormalities of Zika virus infection is done. If on ultrasonography fetal abnormalities are detected, then the pregnant woman is retested for Zika virus infection. If no abnormalities detected, routine prenatal care is followed. This slide shows CDC recommendations for diagnostic testing and techniques for pregnant women with possible Zika exposure. RT-PCR, that is reverse transcription polymerase chain reaction, is done for viral RNA in serum collected less than or equal to 7 days after illness onset. Serology for IgM in serum collected more than 4 days after illness onset. Cross-reactivity can occur among related flaviviruses. PRNT, that is plaque reduction neutralization test, can be performed to measure virus-specific neutralizing antibodies. Information about performance of testing of asymptomatic persons is limited. Once a case of maternal or fetal Zika virus is confirmed during the antepartum period, serial ultrasounds are done every 3 to 4 weeks and the case is referred to a specialist. During the peripartum period, HPE examination of the placenta and umbilical cord is done. Frozen placental tissue and cord tissue is tested for Zika virus RNA. The cord serum blood is tested for Zika and dengue virus IgM and neutralizing antibodies. As there is neither a vaccine nor prophylactic medication available to prevent Zika virus infection, interim guidelines for pregnant women during a Zika virus outbreak have been issued by CDC. CDC recommends that all pregnant women consider postponing travel to areas where Zika virus transmission is ongoing. If a pregnant woman travels to an area with Zika virus transmission, she should be advised to strictly follow steps to avoid mosquito bites. If one or more signs and symptoms of Zika virus infection develops within 2 weeks of travel, serum testing should be performed. Testing can be offered to asymptomatic pregnant women with possible exposure, which could be history of travel to an area with active Zika virus transmission or sex without a condom with a symptomatic male. To ensure prevention of perinatal transmission of Zika, CDC has made some recommendations for both men and women interested in conceiving and not residing in areas with active Zika virus transmission but with possible exposure. If Zika virus disease is diagnosed, wait at least 6 months after symptom onset to attempt conception. If no symptom develops, wait at least 8 weeks after the last date of exposure before attempting conception. Couples concerned about sexual transmission who have traveled to or live in an area with Zika consider using condom or not having sex for at least 6 months after symptoms begin. Consider using condom or not having sex while there is Zika in the area. Prevention of perinatal transmission also involves preventing mosquito bites in pregnant women using EPA registered insect repellents or wearing long sleeve shirts and long pants to cover exposed skin. Brazil has further advised women to use contraception and postpone having a baby for the next 2 years until the Zika situation is well under control. In labor and delivery settings, healthcare personnel working must adhere to standard precautions as Zika virus has been detected in blood, amniotic fluid, urine, saliva, and semen. CDC has established two surveillance systems for pregnant women with Zika virus infection. US Zika Pregnancy Registry for the 50 US states. Zika Active Pregnancy Surveillance System, that is ZAPS, for Puerto Rico. It involves the data collected via medical record extraction. To understand more about Zika virus infection, CDC established the US Zika Pregnancy Registry and, in collaboration with state, tribal, local, and territorial health departments, it collects information about pregnancy and infant outcomes following laboratory evidence of Zika virus infection during pregnancy. If available, data should be collected at regular points. The cumulative number of pregnant women included in US Zika Pregnancy Registry is reported on the CDC Zika website on a weekly basis. Pregnant women with laboratory evidence of Zika virus infection and exposed infants born to these women are included in the registry. Infants with laboratory evidence of congenital Zika virus infection and their mothers are also included. The diagram is a summary of the surveillance effort. Zika is an emerging disease and needs to be studied further. What is clear is the need to rapidly and systematically address identified research gaps. What we know so far is very limited. We know that no evidence of increased susceptibility in pregnant women is seen. Infection can occur in any trimester, but maximum susceptibility is in the first trimester. No treatment or vaccine is available yet. Zika can be transmitted through sexual contact. What we need to work on? What we need to work on is understand frequency and full spectrum of clinical outcomes of fetal Zika virus infection. We need to work on understanding environmental factors that influence emergence. Newer vector control products and strategies are to be developed. We need to still develop vaccine or medication for Zika virus infection. There are some new news material which is available on Zika. 2 suspected cases of locally acquired Zika in Broward County, Florida was noted. Zika virus was detected in Culex mosquitoes in Brazil. Also, a suspected case of female to male sexual transmission was noted. Thank you.